for that. All right, so we are going to move on to introducing the guest speaker for today. So Dr. Hilda Nabiswa is a consultant physician and diabetologist who works at the Moi Kibaki Hospital, which I stated is an annex of KNH-UoN. Other than being young and beautiful and very intelligent, she also has a very key interest in diabetes education. On this note, she is part of the KDSG Administrative Committee. She also is a content creator on YouTube. Her handle is Diabetes Doctor, where she gives advice on all patients living with diabetes on how to manage their disease. She has also supervised a diabetic outreach camp that just concluded in the Othaya region last week, which was a predecessor for this World Diabetes Day celebration. She is a great advocate for patient-centered care in diabetes, of which she is going to tell us a bit about that. Thank you very much, Dr. Hilda, for your presence today. On to you right now. You can start.
Thank you so much, Dr. Ngolobe and Ken, for that kind introduction. Yes, so I don't think there's much else to add there. Just know I am diabetes doctor. That's what I like calling myself because I have a passion for diabetes education and diabetes management in general. So we are going to go through the various subtopics in a very seamless way. I'm not going to have subtopics. I'm just going to go through the topics together, and we will just flow together. Feel free to ask questions at the end, type them in, and I will answer them one by one. So without much further ado, let's start. Let's start with diabetes around the world. These are statistics from last year. And they just tell us how diabetes is going to increase in the different continents by 2030 and then 2045. And what I want you to note is that all the continents will have an increase in diabetes. However, I want you to notice Africa over here. We are the only continent with a 3-digit increase, 134%, while others are having 13% in Europe. We are doing 134%. Why? Because of poor education, because of lack of infrastructure to enable us to live very healthy lifestyles currently, because of starch-based diets. There are so many reasons why we're going to have such an increase in diabetes. But one of the things that I want us to leave today knowing is that we have a role in educating the people around us so that we do not have to rise to the 134%. We can be the people who go out there to ensure that diabetes is actually going to decline if people follow what we are set out to talk to them about. So 1 in 22 adults in Africa are living with diabetes currently. That's around 24 million adults. The total number of people with diabetes is predicted to increase, like we've said, to 55 million by 2045. And the sad thing is that over half of the people living with diabetes are actually undiagnosed. So many people are out there who don't even know that they have diabetes. The majority of them actually. And last year, 416,000 people died because of diabetes in Africa, and 1 in 8 live births were affected by hypoglycemia in pregnancy. That tells us a lot. This is data from the IDF. And about undiagnosed diabetes, the quote that they said that they've specifically written in their notes is, people with diabetes in sub-Saharan Africa are dying younger than everywhere else in the world. So not only are we going to have an increase of 134%, but already people are dying from diabetes more than anywhere else in the world. And why is that? Well, in 2015, there's a study that looked at the various causes of death from different diseases. They looked at people who died from diabetes, HIV, AIDS, TB, and malaria. You can see the numbers. AIDS, 1.5 million. TB, 1.5 million, 0.6 million from malaria. But look at diabetes, 5 million people, 5 million, 2015. And so, you sit back and think, we put so much focus on the communicable diseases and we forget the non-communicable diseases, and they're the ones killing people. And 79% of those deaths occurred in people under the age of 60. And that's why IDF has put a strong sentence to say that Africans are dying disproportionately, especially the young people. And that means that we really need to improve the investment, the research and health systems that we have so that we can respond better to non-communicable diseases and stop being so focused on infectious diseases, because we are focusing so much on HIV and malaria, and diabetes and hypertension is killing us. And why do we get these complications, and how do they come about? Well, the complications can be divided into microvascular, macrovascular, and non-classical complications. So microvascular complications include the eye, the kidney, and the nerve. And by the way, they usually are like a triplet. Whenever you see someone with diabetes coming and telling you, hey, daktari nasikia nachomeka miguu, just know that the eye is probably going to follow soon or is already there, and the kidney is also following soon. So those microvascular complications usually tend to occur together. And so these are patients who, every time you see someone with neuropathy, ensure they have a microalbuminuria screening for their kidney so that they don't present when the creatinine is already 1,000 and they need dialysis. Macrovascular complications, that includes coronary artery disease, heart failure, peripheral arterial disease, and stroke. There's a day I did a random check of the pulses of the patients who came to the endocrinology clinic at Moi Kibaki Hospital, and 5 out of 20 something had reduced pulses. So they had peripheral arterial disease already, but it is hardly ever looked for. We do not examine our patients well enough to be able to tweeze out some of these things. So it's always a reminder. Don't wait for someone to present with gangrene for you to say, oh, there's peripheral arterial disease. No, look for it. Look for it. Same as the kidney. Look for the protein leaking before you end up with lower limb swelling and a creatinine of 1,000. It always starts with leakage of protein. So we need to be more proactive in looking for these complications. And now there are even other complications that people never, or we usually don't really take them very seriously, or we forget them. One of them is cognitive impairment. There's a lot of cognitive impairment and depression in diabetes. Up to 50% of people with diabetes get depressed. And then non-alcoholic fatty liver disease or non-alcoholic steatohepatitis is also one of the very common complications of diabetes. So always put this in mind whenever you're looking at the patient in front of you. And, you know, sometimes we ask, why do our patients die, or why do they get complications? Why are they getting so many complications? In the ward, we have so many patients who we start on dialysis. Every week, I think we have a new patient starting dialysis. We have people who come in with clots in their legs, and you wonder why, what's happening? So one thing that we need to all know is that if a patient, for example, when you compare one who has no diabetes and then one with the diabetes, and one who has had diabetes and a myocardial infarction, diabetes already takes out 6 years of a person's life. And then when you add complications like a heart attack, heart failure, you subtract another 6 years, and it becomes 12 years out of someone's life just because of diabetes and its complications. So it's very important to note that already when you get diabetes, it's already it reduces the years on earth, and complications make it even worse. And when you look at the causes of death of people with type 2 diabetes, majority of them actually die from cardiovascular disease, and it's hardly mentioned. And that is, I think, one of the reasons why we really need to improve how we write our death notifications and causes of death, because someone will die and people just say cardiorespiratory arrest without thinking what has led. All of us will die through cardiorespiratory arrest. It's the mechanism of death. But what is it that led to the death of this person? So such patients, it's very important to say, you know, cardiovascular disease, and then secondary to diabetes, hypertension. Let those words come out. Maybe that way we can have more and more engagement with the policymakers, because now it will be actually data coming in that indeed we are seeing more deaths from diabetes, more deaths from hypertension, and that will make the focus shift from communicable to non-communicable diseases. So always remember that cardiovascular death is or disease is the top cause of death in type 2 diabetes, followed by kidney disease, and then cancers and other come thereafter. So just like we've said, it's a continuum, and it's actually, when you look at type 2 diabetes, it doesn't come by itself. It comes with cardiovascular disease, and it comes with chronic kidney disease. And these three together are what actually reduce life expectancy of patients, especially when it meets here in the middle. Whenever you think of a patient who has diabetes, has heart failure, has kidney disease, just know that this patient's life has been shortened by very many years because of these comorbidities. So our main goal is to avoid getting our patients getting here. We want them to either just be living with type 2 diabetes alone without getting heart failure, without getting CKD, without getting both. Because the minute it gets here, their life expectancy is much less. So what can we do? It's not hopeless. We can still do something about this. And that's the main reason why we are having this lecture today. I will not even delve so much into treatment of diabetes in terms of medications. That one we can do another day. But what I want to bring about is the fact that we need to approach the diabetes in a different way and help the patient understand what they have. And that way we can reduce the number of complications that we are getting from diabetes. So one of the things we can do is to increase the awareness and increase our screening, because like we said, more than 50% of people living with diabetes don't even know that they have it. So targeted interventions like screening and sensitizing the population, that helps in increasing diagnosis. Actually, in the camp that we had a few days ago, we were able to newly diagnose a number of people with diabetes. There's one who came and hypertension. Then we had a number who had pressures of 160s or 100, sugars of 12, sugars of 19, 16, 20, and all this was new. They didn't know. Then that way, once you get someone who is generally asymptomatic, it's good because it means you're probably getting them at an earlier stage compared to getting a patient who already has renal failure, and that's when you're doing your diagnosis. So screening helps you to get it early, just like in malignancies. And then when you get the patients at an earlier stage, then it's also easy to even get them through to go through remission. By the way, diabetes remission is a thing. And what we mean is that you just because you have diabetes, or just because a patient gets diabetes, doesn't mean that they have to live forever with high sugars or on medication. It is possible for some, especially those who come early, if they change their lifestyles, type 2 diabetes that is. For example, those who are obese, if they're able to lose weight, if they're able to change their lifestyle to a healthy lifestyle, diet and exercise, it is possible to actually go through remission and actually revert and go back to a non-diabetic state. However, we always have to walk the journey with them because they can easily revert and go back to their old lifestyle and get diabetes again. But it is important for us to always encourage those who can to go through remission. And then very importantly, we can offer diabetes education, which is one of the key topics of discussion today. And it's also the theme of the World Diabetes Day today. The theme is actually education for a better tomorrow. And that's exactly what we need. We need a better tomorrow for our patients. We want them to see tomorrow. So what do we do when it comes to screening? So the current guidelines say this: all adults without risk factors should be screened with a test for prediabetes and type 2 diabetes starting at age of 35, not 45. It used to be 45, but then they realized that, you know what, younger and younger people are getting diabetes. And Corona taught us that. I don't know how many of us were able to get very many new diagnoses of prediabetes and diabetes in people in their 30s. I saw quite a number. Because of the sedentary lifestyle, people are not moving, they gained a lot of weight during the COVID season. And there was an increase, especially in the young population. And so it's important to note that without risk factors. It doesn't mean that just because you go to test for your sugar because your father has diabetes and therefore you feel like you have high risk for diabetes. No, as long as you're an adult of age 35 and above, kindly get a fasting blood sugar, get a HbA1c done for you. Diabetes does not have a face. It can happen to anyone. Now, the other thing, the new standards of care emphasizes that screening with a fasting glucose test for undiagnosed diabetes in all women who are planning to get pregnant, especially if they have risk factors. So remember, this includes people now who are less than 35 years old. So all people 35 and above, whether you're getting pregnant or not, it doesn't matter, you get screened. But even if you're 25 and you're planning to get a baby, get a fasting blood sugar because you never know. So what we are saying is that all women who are planning to become pregnant should be screened. Then for any unplanned pregnancy, women should be screened at the first prenatal visit. So this is the screening that is currently recommended for diabetes. So just take a note and ensure that wherever you are, at your workplace or where you work, your clinic, make sure that these are things that are actually followed through. Get a sugar for everybody. Now, one of the things that you can do to check your risk for diabetes is a very free test. It's connected to the ADA, and it can calculate your diabetes risk. So this is the site, and I would recommend and encourage you to go onto this site. So you can actually have a high risk for diabetes type 2 and you don't know whether you're a healthcare provider or not. So ensure that you know what your personal risk factor or your risk for type 2 diabetes is by doing this risk testing tool. When we come to classification of diabetes, this is just a reminder that it can be classified according to the following general categories. Type 1 being that there's an autoimmune beta cell destruction, which leads to absolute insulin deficiency. And this includes latent autoimmune diabetes of adulthood, which usually looks like type 2 diabetes in an older person, but they generally will require insulin faster. So latent autoimmune diabetes of adulthood is called LADA, and it's very many times confused for type 2 diabetes, but they tend to require insulin faster. And in our subsequent lectures, we will have a lecture on LADA. Then there's type 2 diabetes, which is a progressive loss of beta cell insulin secretion, frequently in the background of insulin resistance. Now, this is our current monster. Type 2 diabetes is a monster. Why? Because of the associated obesity, the associated sedentary lifestyle that has been on the rise in all the continents, including Africa. And that is why we're getting more obese people, we're getting more insulin resistance, and we're getting more type 2 diabetes. Now, there are other specific types of diabetes. There's monogenic diabetes syndromes, these are the people who have neonatal diabetes, maturity onset diabetes of the young, diseases of the pancreas, drug-induced diabetes, such as those with who are on steroids. People who are being treated for HIV and AIDS actually have more diabetes, and there are more studies coming out that are showing the correlation between HIV, AIDS, and non-communicable diseases, and after organ transplantation. Then gestational diabetes, which happens in the second and third trimester of pregnancy in someone who was not overt diabetes before the gestation. So this is just a reminder of the classification. We won't go so much into it, but we can always have different classes, especially of LADA and MODY. MODY is maturity onset diabetes of the young. That one is a whole lecture by itself as well. But just a reminder about that. And then again, a reminder about diagnosis of diabetes is that anyone who has a fasting blood sugar of above 7, and fasting is defined as no caloric intake for at least 8 hours, or a sugar of more than 11.1 after an OGTT. And the WHO guidelines states that you need 75 grams of glucose dissolved in water. And thereafter, 2 hours later, if your sugar is above 11.1, then you are considered to have diabetes. Or an A1C of above 6.5%. 5.7 to 6.4% is considered pre-diabetes, and then above 6.5% is diabetes. And then anyone who has classic symptoms of hyperglycemia, that includes polyuria, polydipsia, polyphagia, or anyone who comes in a hyperglycemic crisis and a sugar of 11.1 and above, that is diabetes. So these, when we're talking about diabetes, this is what we're talking about. And remember, sometimes there are no symptoms. Sometimes you get a patient who tells you, no, I was told my sugar was 9, I had not eaten, but I was just feeling okay, so I don't think I have diabetes. So it's a reminder for you to tell them that it's not about the symptoms, it's about the numbers. As long as they fit these numbers, they are diabetic. So our targets when someone has diabetes is for them to have an HbA1c of less than 7%. And generally, for us to achieve that, we need to target for a fasting blood sugar of 4 to 7 and a 2-hour postprandial target of 5 to 10. So this is generally what we tell our patients who are living with diabetes, that even if they're not able to afford a HbA1c, because I know this sometimes is a limiting factor. Some people don't have the money to do this every 3 months or every 6 months, but they can at least do a fasting blood sugar once in a while. And whenever they do it, they need to target a sugar of 4 to 7 and a 2 hours postprandial sugar of 5 to 10. And it's very important for patients to be taught how to manage their sugars from home, and for them to know how to even record and test them for themselves. That is self-monitoring of blood glucose, very important. And it's part of diabetes education, as we're going to look at. Now, when we have our patients in front of us, we need to remember that there's something called individualization of glycemic targets. This means that the way you treat me is not the same way you treat Dr. Ngolobe. It's not the same way you treat Kennedy. We all have our different features, and you need to put that into perspective before you decide which drugs you're giving us, before you decide what kind of sugar you want us to have. Remember, we said that we want a target of 4 to 7, but for some people, you will want it to be a tight target, which means around 4 to 5.5. But for some, you will allow 6 to 7. For some, you will allow a postprandial of 9 to 10. But for some, you want it to be between 5 to 7. Why? Because you want a very tight control. And this is what will help you to know who is going to get a tight control and who you're going to be less stringent with. So this particular guideline came from the ADA. This is the 2021, but it's been there for a while. And it basically tells us how we need to individualize our patients. First of all, we need to look at them in terms of what kind of risk of hypoglycemia is there. Just today, I've been told by someone in casualty that there's a patient who presented at Mwai Kibaki Hospital with a history of recurrent hypoglycemia and has been using insulin. And so now we've had to actually switch them and see whether we can do on orals rather than insulin, because they're getting recurrent hypoglycemia, which is extremely dangerous. So anyone who has risks associated with hypoglycemia, perhaps they have very poor feeding, especially the elderly, sometimes they don't eat, they miss meals, they miss, so because you're not very sure about that, you really want to avoid hypoglycemia at all costs. So those are people whose sugars you can allow to be higher than the average. You can allow them to have a postprandial of 10, 9 to 10, and a fasting of around 6 to 7 or even 8, because you just want to avoid that hypo. But anyone who has a low risk of hypo, then you are tight with their control because you're not worried about a hypo. Disease duration is another one. People who are newly diagnosed, you want them to have a tighter control than people who have had long-standing diabetes for more than 20 years. Life expectancy, very important. Sometimes we are called to the ward and we are told about this stage 4 cancer patient who has very high sugars. But at the end of the day, you look at the patient and you're wondering, what will kill this patient first? Is it the cancer or is it complications from uncontrolled diabetes? It is most likely the cancer. And so because of that, you don't want to be too tight with them, and also bearing in mind that they're at high risk of hypo because they probably are not feeding well. They might be having lots of diarrhea, the medications that they are taking. And so you want to have a less stringent control. Important comorbidities. Have they had a recent heart attack? Have they had kidney disease? So it's very important to know, is this a renal dialysis patient in front of you? And if it is, then you want to have less tight control of such a patient. You want to avoid hypoglycemia and you don't want to be too tight on the control. There's a study that was done a few years ago to check whether very intense control was beneficial, like a HbA1c of 5%, 4%. And there was actually increased cardiac mortality, especially in the people with comorbidities. So older people with the important comorbidities, do not be too tight on their control because you can actually increase mortality. Established vascular complications, that MI, stroke, if they have very severe complications, you want to be less stringent. Then patient preference. This is extremely important because today we are talking about patient education and involving the patient in our decision making. What you've probably seen is that if a patient does not want certain drugs, they will not take them. They will take your insulin very nicely, but they'll go home and they will not inject themselves. They will decide to go to that mitishamba, that doctor who told them that within 3 months they will cure their diabetes. So you have to work with the patient's preference. It's important for you to know and see, what kind of patient do I have in front of me? Are they very motivated? Can they take care of themselves very well? And if they can, then you will be tight with them. But if they do not want burdensome therapy, they are not keen on insulin, they're not keen on various things, then you want to be a bit gentle with them, because if you are too tight on them, you'll end up having a worse outcome. And then resources available. So anyone who has very ready resources, like this one over here, then you can give as much as you want. But those who have limited resources, then you also want to look and make sure that you modify your treatment to fit into what the patient has, the resources around them, and what they have inside them, how motivated they are. So now we come to our topic at hand, putting the patient or the person with diabetes at the center of care. And this is going to be a recurring theme. So according to the 2022 guidelines, these are now the latest guidelines for this year. The ADA and EASD, that's the Americans and the Europeans, came together and decided to create something called a decision cycle. And we also from Kenya endorse this because it really is a very good cycle. And I want to take you through this because this is what we are really trying to look into today. So it's called a decision cycle. Why? Because both the patient and the caregiver are focused on the goals of care, which are preventing complications and optimizing quality of life. At the center, that is always what we want. We're not looking at a good sugar just because we want a good sugar. We want it because we know that we are trying to prevent complications. We need to reduce the number of people going for dialysis, reduce the number of people having heart attacks, having neuropathy, having retinopathy. That is our goal. And we also want them to be comfortable. So this is how we are going to go around it through the decision cycle. So let's go through it step by step. So first of all, assess the key person characteristics. Look at the patient in front of you. What are their priorities? What is their lifestyle and health behavior? What are the comorbidities that they have? And what are their characteristics? How old are they? What's the HbA1c? What is the weight? And look at whether they're motivated, whether they're depressed, whether they have cognition issues. Some of these people actually have diabetes, yes, but they have had strokes. They cannot take care of themselves very well. Their cognition is impaired. And other social determinants of health, which includes money, because we all know diabetes, taking care of diabetes can be expensive. And you have to put this into consideration. You don't want to start a patient on a drug that they will not afford in the long term. So this is extremely important. So you start with that, assess the patient in front of you and look at them and decide, okay, based on this person, then what next? So look, based on the characteristics that you have seen here, then now you consider any specific factors that will impact the choice of treatment that you want. For example, there are some people who the main goal of treatment is to bring down that HbA1c from 12% to 7%. So for that is glycemic goals. But for some, it's you want that weight to go down. In the camp, we had someone who was 140 kilos, but had reduced to 120 and wanted to reduce more. So that means for her, her main priority is weight. She wants to lose weight. So you need to ask yourself, how am I going to help this patient to gain her confidence and get her weight down and believe in the teamwork that we're going to have, both of us, so that we accomplish this goal. Then look at the impact of the medication on their weight, on hypoglycemia, and cardiorenal protection. This is very important. Why weight? Because the more weight someone has, the more insulin resistance, probably the more insulin they will need, or the more the medication they will need. And so don't give them medication that are going to just make them gain more weight, because the more weight they gain, the more insulin resistance they have, then it's like a never-ending cycle. Then hypoglycemia. So anyone who is getting hypos, you have to quickly check the choice of treatment, and we're going to go into that. Cardiorenal protection is very important. Right now, we have drugs that are able to protect someone's kidneys, someone's heart, and help them reduce the complications that they will get in future. And like we said, our main goal of care is prevention of complications. So anything that is going to protect a heart, protect a kidney from complications, we need to use those drugs. Any underlying physiological factors like malignancies or any other issue they might have, side effects of the medication, very important, complexity of the regimen. For example, if you're going to start a patient on insulin and they already tell you, daktari mimi kujidunga ni ngumu, and then now you want to put them on a basal bolus regime, which means injecting themselves 4 times in a day. That is being unfair to the patient. You're being unfair to the patient, and you're probably going to make them not compliant because they just are not going to be able to keep up with the complexity of that treatment. Then the regimen choice that will optimize medication use and reduce treatment discontinuation. So always remember that at the end of the day, you want to make sure you're optimizing them using their medication. Don't give them drugs that are going to make them less adherent. Then look at access, cost, and availability of medication. Then now, based on those, you now go to the next step of shared decision-making with the patient, creating a management plan. So first of all, you ensure that they have access to a structured diabetes self-management education and support program. We are going to look into that. And then involve an educated and informed person. And especially if the individual has a family or a caregiver that is always by their side, involve that person. And that's why in the clinic, and I really like it, that the endocrinology clinic at Moi Kibaki, they always insist that if it's an old person especially, they have to come with someone who is educated and who is going to inform the patient further. We don't like seeing an 80-something-year-old coming in alone, because many times whatever you tell them might not really, they won't really understand some of the things you're trying to tell them. Exploring personal preferences, language matters, and we're going to look at that. We always need to use empowering language to our patients. And then do motivational interviewing, which means look at the interview the patient in a way that you're trying to also assess how motivated they are to the treatment. Goal setting and shared decision making. So this is basically including the patient now in your plan and educating them so that they understand why you're treating them the way you want to treat them. For example, if you want to really focus on cardiorenal protection and you know that there's a drug out there that can help their kidney or their heart, tell them about this drug and explain to them why you're giving them this drug. And sometimes they'll say, Doctari, it's expensive. But sometimes I ask them, it might cost 1,000 shillings more, but this 1,000 shillings can be the thing that is between you and dialysis in the future, and it can help to prevent the complications that come with dialysis. So when they look at the bigger picture, then they will be able to understand and say, okay, now I understand why doctor is giving me this medication. Okay. So always involve the patient in your decision making. Then the next thing is agreeing on a management plan. So identify SMART goals. SMART is the usual SMART: specific, measurable, achievable, realistic, and time limited. For example, if you want the patient to lose weight, we all know that people with diabetes type 2 and obesity have to lose weight. Why? Because it reduces insulin resistance. So if a patient has a kilos of like maybe 130, you can't realistically expect them to lose 30 kilos in 1 month or in 2 months. You have to set goals that are actually achievable and that they can see how they can actually get there. So tell them, in the next 3 to 6 months, I want you to lose X amount of weight, usually 10 to 15% of their body weight. So that's around 13 to 18 kilos in 3 to 6 months. That is very doable because that's around 3 kilos in a month. And then now you guide them how they're going to go around that. So give them SMART objectives, then implement the plan, and always continue doing regular review. And especially for those who need more education, do frequent reviews, because you need to keep on seeing how they are implementing this plan. Okay. Then the next is provide ongoing support and monitoring of their emotional well-being, their lifestyle and health behaviors, tolerability of medication, and biofeedback. How do you measure biofeedback? This is using data that you can see, like blood glucose monitoring. We don't have continuous glucose monitoring for most of our patients, but just them doing their blood glucose monitoring, doing their fasting blood sugar regularly, postprandial blood sugar regularly, and coming back to you with the results. Let us not be in this habit of waiting for the patient to bring only one sugar, that sugar for the clinic day. You have to encourage them to go out there, even if they can't afford the machines or the strips. What they can do is that they can just go to the health center, do a 50 bob test, fasting blood sugar maybe once a week or once every 3 days or so. And with even 500 shillings, they can have 10 blood sugar recordings in a month, which is good enough because it can tell you where you're headed with your medications and whether you're actually doing a good job. And then after some time, you now review and agree on the management plan, and then agree on the changes that need to be done. And this includes even starting on insulin. I know there's a patient that I have been struggling to start on insulin from January, and he only accepted it last week. And it's because we were going through all this. And I could tell his priority was not that. And slowly I had to motivate him and talk to him about the importance of insulin. And by the time month 10 came, he was now ready. And so we went with his time, because I knew if I started him on insulin and then he would probably just not do it, and he'll just get lost to follow up, because that has happened to so many patients. So get the patient on your team, get the patient to agree or work with you, so that you can see how to work together towards making sure the management plan is a success. And make sure that we do this decision cycle at least once or twice a year, involving the patient and operating in an integrated system of care. How? By including not just you, but the support staff, the people around you, the nutritionist have to be there, the diabetes educator if you have them, the surgeons, the ophthalmologist to check the kidney, the heart, the eyes, nephrologist if the kidney is involved. So making it a multidisciplinary approach. It's not a one-man show. So once you've done that decision cycle, it's always important to always know where your patient is at and the kind of drugs that you want to give your patient. And this is just a reminder again that at the beginning of every person who has diabetes, there's a healthy lifestyle behaviors, interventions, diabetes self-management education. By the way, the biggest person who will support that patient in managing their diabetes is themselves. It is not the doctor, it is not their caregiver, unless of course they are cognitively impaired, but it's very important for the patient to understand that they are the center of care, and they need to also have that self-drive. Not everything can come from their doctor or from the people around them. It has to come from them as well. Then the social determinants of health. And then once you've streamlined this, then you also look at whether your patient has risk factors. Do they have diabetes? Do they have heart failure? Do they have coronary artery disease, or do they have kidney disease? And whenever they have that, then you really need to assess for cardiorenal risk reduction. And we are going to go through that particular goal of therapy. And the reason I was bringing that in is because right now, our focus on diabetes treatment is not just about sugars. When I was in medical school, I remember the main concern was sugar, sugar, sugar. But now it has become, there are 4 different pillars of treatment. You can see this is a house. And what we say is that at the base of this house, the foundation is always lifestyle modification and diabetes education. Without these, the house will not, you will not build. Your pillars will be on a very shaky foundation. You have to make sure you've laid a good foundation. And then now the pillars of management are glycemic management, making sure your sugars are okay, blood pressure is well controlled, cholesterol is well controlled, and using agents that actually benefit the heart and the kidney. I cannot mention this enough, because I think we prescribe these medications. We need to always remember that for anyone with diabetes. If they're at risk, always give them agents that will benefit them as long as they can afford it. And once you have those pillars of treatment, then the roof is a very happy patient, because you have reduced their diabetes complications, which is what we want to achieve at the end of the day. And this is just a reminder that there are different hypoglycemic agents. We all use these to treat diabetes. We have things we use a lot, biguanides, that's metformin, thiazolidinediones, that's pioglitazone. They increase peripheral glucose uptake in the adipose tissue and skeletal muscle. Then we have insulin itself, and we have sulfonylureas and meglitinides. Sulfonylureas, the most common is glibenclamide, but we have newer sulfonylureas like glimepiride, gliclazide, which increase insulin secretion from the pancreas. Then we have kidney glucose reabsorption reduction by SGLT2 inhibitors, which we'll talk about shortly. Then we have reduced gluconeogenesis from the liver by metformin and pioglitazone. And then we have acarbose, reducing glucose absorption from the intestine. We also rarely use it. Majority of the time we use these ones over here. We use sulfonylureas, and we also of late have been using a lot of SGLT2 inhibitors, which are very important medications. Why? Because they work beyond sugar control. It is not just about sugar control for SGLT2 inhibitors. It is more than that. It is about protecting your heart and your kidney. And these are the mechanisms in which it works. It looks like quite a bit, but at the end of the day, just know that what happens is that you have more glucose in your urine. That leads to a negative caloric balance, reduced HbA1c, and increased uric acid in the urine, which generally leads to less inflammation in the system, reduced body mass fat, even the fat around the heart is reduced. And because of that, your cardiac contractility is better and you have less atherosclerosis. Then there's also natriuresis, which means you have more water passing through the kidney and ending up as urine. And because of that, you have less plasma volume, less blood pressure, and increased tubuloglomerular feedback. And that protects your kidney. At the long term, remember, one of the pillars of management was making sure that you've protected the heart and the kidney. But the other pillar of treatment was making sure that your blood pressure is well controlled. A lot of people with diabetes have hypertension. And you always need to remember that the target for treatment, the target for blood pressure in people with diabetes is a BP of less than 130/80. If you don't have that, then you are not still managing your patient well. You need to reduce your blood pressures to less than 130/80 and use the agents that are going to help your kidneys as well. So anyone who has albuminuria or coronary artery disease or CKD, make sure they're on an ACE inhibitor or ARB. Then you can add a second choice of calcium channel blocker or a diuretic, or you can use all three, ACE inhibitor or ARB and calcium channel blocker and diuretic. So always remember, at the end of the day, you want your blood pressure to be less than 130/80. And anyone who is not meeting the target of blood pressure, make sure you add a mineralocorticoid receptor antagonist. That also reduces your kidney disease. But if it's not targeted still, always refer. Remember, that's why we have a referral system, because people who are not getting managed well, to prevent complications, make sure that you can refer them as soon as possible to a place where they can get the help. I will not go so much into this slide. It's one that I like giving you because teaching with it, because it gives us the different medications and their side effect profiles and what kind of effect they have on weight, on sugar, on the heart, and on the kidney. And I'm sure Kennedy will disseminate the slides, and you'll be able to go through all of the drugs one by one. But my take-home message to you is, don't just prescribe drugs because they're there. Oh, kila mtu wa diabetes, metformin, no gluc, metformin, no gluc. That is what is done out there. And it's really, sometimes I feel very sad, because it just shows that people do not know why they're giving the drugs that they're giving. Remember, you do not target everyone the same. You have to look at the patient in front of you. What are you looking for? Do you want them to lose weight? Do you want to protect their heart and their kidney? Do you want them to reduce hypoglycemia? So you choose your drugs based on the kind of patient in front of you. It's not a one drug fits all kind of picture. Now, the other thing I also want to bring into consideration is that on top of medication, there's the role for surgery. So people can actually get bariatric surgery as a treatment for diabetes, as a treatment for hypertension and obstructive sleep apnea. And usually there's a lot of weight loss achieved, and it reduces cardiovascular risks such as lipid profile and hypertension. And the current guidelines say that people who have a BMI of above 30 are obese, and 27.5 for Asians. Them obesity is actually a lower BMI. But those who have class 3 diabetes, obesity, BMI of more than 40 kg per meter squared, those are people who you can actually just consider immediately for metabolic surgery. And nowadays, diabetologists, endocrinologists, and surgeons work hand in hand. Diabetes is no longer a medical thing alone. Diabetes can be treated through surgery. And this is very important. You also need to understand this, because for those patients who have been trying to lose weight and nothing is happening, and you're just increasing the number of medications they're on, sugars are poorly controlled, you might want to step back and actually think about metabolic surgery. One of good success stories is Big Ted. And I know some of us know Big Ted. Kama unajua Big Ted, I hope you have started planning for your retirement, because yeah, your age is now catching up. But basically Big Ted used to be very obese, and now he has lost quite a lot of weight, and he also reversed his diabetes and hypertension through weight loss, but he had a bariatric surgery. And this can happen, this success story can happen to many other people out there. And we need to encourage that open-mindedness, so that we are not just boxing patients into medications throughout. If your patient can afford it, and if they can get to a space where they can get this kind of service, by all means, let them do it. Now, when we still talk about beyond glycemic control, we are talking about looking at the patient with diabetes, but also looking at what else comes with diabetes. Heart failure comes with diabetes. Chronic kidney disease comes with diabetes. You want to protect the kidneys and the heart. And you want to use this medication in people who have diabetes and even those without diabetes. And making sure that we have cardiac risk stratification of patients, and we give drugs according to the risk of them getting kidney and heart problems. So that was just the part about complications and how to choose medications for different complications and the role for SGLT2 inhibitors in management. But I'm going to again go through it in a few minutes. So the reason why we include diabetes education as first-line therapy before you even start your medications is that it really has been seen to increase or improve outcomes. And there are various types of initiatives that have been there throughout Africa. In Kenya, you can see we actually have various short courses for nurses. There's actually one that was being offered by Roche Pharmaceuticals just a few months ago in partnership with KDSG. In Congo, they do outreaches to people with diabetes, and they teach them. They actually take them through class. In which country is this? In South Africa, they do online courses, again, for professionals. In Congo, they do online courses for both people living with diabetes and professionals. In Nigeria, there's workshops that they do for various cases. They have specialized workshops even for professionals. How do you examine a foot? How do you take care of a foot? In Dakar, we have hospital-hosted patient education. And when I saw this, I thought, we have so much that we can do. As much as we usually complain that we don't have money, but some of these things actually do not need money. There's nothing that is keeping us from actually just saying, today we are doing an open day for diabetes. We are involving the area MCA, bring your people with diabetes. We organize like a small seminar for them and we teach them. And those are things that we can actually do without any budget. So we don't need to have money to do these things. We can just do them and ensure that we are impacting education to our patients, but also for ourselves as healthcare professionals. There's a lot that we still need to learn. There's a lot that we need to always sharpen our skills with. And I always want you to think and ask yourself, what is it that I can gain? What is it that I don't know that I can go and learn more about? So there are so many online courses, and at the end of the feature, I'm going to show you a particular place where you can go and get a short course on diabetes if you're interested. And there's a study that was done across board, a meta-analysis of various studies looking at how much diabetes education is given to patients and how comfortable they are with managing their diabetes from home. And you can see Kenya did very poorly. We did 20%. So only 20% of our patients are actually comfortable with managing, checking for their sugars at home. They know how to titrate their insulin based on what their sugar is. Diabetes education is quite wide, and it's not just about telling them what diabetes is. It goes beyond that. They need to understand so much more. Kenya was given a score of 20%, which I think is true. We really need to improve. So self-management education is the process of teaching persons with chronic disease to manage their illness and treatment by providing them with the knowledge and skills that are needed to perform self-care behaviors, manage crises, and make lifestyle changes. And this means that in an area like South Africa, for example, they have reached the point where mild DKA is treated from home. They are able to manage crisis from home. They tell the patient, you know what? When your sugar is less than 12, you take Coke. When the sugar is 12 and above, just keep on injecting your insulin every 4 hours and measure your ketones using a ketone strip. And they do their DKA management at home. That is what we mean by self-management education. If we get to a point where our patients are able to know so much that they can even manage mild DKA at home, then we will know we have done our work. So far, bado tuko mbali sana, sana, sana. And part of the reason why we do this is because it's very important to have that shared decision making and enable them to understand the quality of their decision, to know the risks, safety, and benefits of various medications, and incorporate their individual preferences and values when we are formulating the management plan. So it's very important for them to first be educated so that now they can have decision making from a point of knowledge. Otherwise, it's just you telling them what to do and being authoritative about it, which is usually what we do. So we need to step away from that, mimi ni daktari na nimesema. We need to stop that kind of approach and start working with the patient, okay? So looking at diabetes self-management, education, and support, that is DSMEs, it keeps on coming up over and over again. And what it is that it's a face-to-face contact in a group or individual sessions with trained educators. I know we have very few educators around, but even in our hospital at Mwai Kibaki, we actually have 2 educators already, and we have a partner, that's Novo Nordisk, that has partnered with us to ensure that they provide diabetes education to those who need it. And they actually do individual sessions. And that ends up promoting healthy eating, physical activity, good medication behavior, taking behavior, and increases self-efficacy. And through all this, it has been shown that when you have contact time of more than 10 hours of continuous education, there is reduced HbA1c, generally, so better glycemic control, reduced admissions because of hyperglycemia and DKAs, improved person with diabetes knowledge, improved clinical and psychological outcomes. It is more cost effective because at the end of the day, you're using less for complications, and it actually can reduce the risk of all-cause mortality. And I mean, that is what we want. Our patients are dying. We kept on saying, why are they dying? Why are they dying? It's because they don't know what to do. It's because we are lacking when it comes to diabetes self-management, education, and support. And this is why this is extremely important, and we really need to improve. And when we are talking to our patients, we always need to remember that we need to use language that is neutral, non-judgmental, based on facts, actions, and biology. You need to tell them you have type 2 diabetes, it's because of this and this and this. Your risk factor is because you are obese. You need to lose this amount of weight. Use facts. And then use language that is free from stigma. The many times I have seen stigma in diabetes is when people are being told about insulin. Insulin is always made to look like this demon that has come from I don't know where. Unajua ukiendelea hivi mama nitakuanzisha insulin. Vile unaenda si vizuri, utaanza insulin. So it makes them think that insulin is this animal that just needs to be avoided. So let us stop stigmatizing medications. Let us use language that is free from stigma. And even when you see someone who's very big or obese, sometimes you get people who are saying, unajua hii ni unono yako ndio imekuletea hii ugonjwa. So let us try and make sure that we are very careful about how we talk to our patients. Use language that is strength-based, respectful, inclusive, and imparts hope. Use language that fosters collaboration between the patients and us as healthcare providers, and use language that is person-centered. So nowadays, we don't say diabetics, we say person living with diabetes. So people living with diabetes, not diabetics, okay? Why? Because we are trying to move away and make them feel included, make them feel like they're not judged, and give them more respectful and strength-based language. So use empowering language always. When you talk to anyone with chronic disease, this is not just diabetes, hypertension, diabetes, asthma, HIV, etc. All of them, you have to use empowering language because they are the ones who are living with this condition. So now I'm coming to the end of the lectures, but I want us to now summarize and put everything together. So we have said we want person-centered approach to type 2 diabetes management. At the center of everything is the patient, and our goals of care are prevention of complications and optimization of quality of care. The components of care, one of them is glycemic management, meaning you want your sugars to go down, because at the end of the day, sugar going down is what will reduce your complications. Then you also want weight management. You want drugs that are not going to make your person gain too much weight, because more weight is more insulin resistance. Then you're caught in this cycle of always trying to increase medications, but the issue is the weight. Then cardiovascular risk stratification. If you have a patient who has a high cardiovascular risk, they are a smoker, their sugars are poorly controlled, the pressures are high, the cholesterol is high, always manage those cardiovascular risks, because those are the ones which now end with complications. Then at the end of the day, use drugs that are protecting your kidney and your heart. So your choice of medication should always bear that into mind. And at the middle of all this is the principles of care. The principles include complication surveillance and screening. Examine your patient well, check for neuropathy, check for retinopathy, send them to an ophthalmologist every year. Health behavior modification, talk to them so that they can change. Send them to a counselor if they need it. Monitoring and ongoing review. Reduce your risk of hypo. Remember, hypoglycemia kills. So if you need to reduce that insulin, reduce it. If you need to stop the insulin, stop it. If you need to stop the sulfonylurea, stop it. Change it to something else. Effective practice and organization of care. Consider underlying pathophysiology. Avoid therapeutic inertia. A patient who needs to be started on insulin should be started on insulin. By the time they're on maximum dose metformin, maximum dose glibenclamide, sugars are still 16, they're still 14. Don't wait for complications to come for you to say you're going to change to insulin. That's a patient who needs to be changed to insulin. Do not have inertia. And we are going to have a whole topic on inertia later on. Look at the social determinants of health. How much money do they have? Which medication will I give them that will help them but will not be too expensive for them? Psychosocial factors, again, counselor. Diabetes structured education and support, extremely important. Language matters. Talk to them nicely, empowering language, shared decision making, empower your patients so that you can now discuss. It's not a matter of you just telling them what they're going to do and forcing things down their throats. Consider local healthcare setting and resources. So don't start talking about continuous glucose monitor when you can't even afford a glucometer. So make sure that you do not go above the budget of the patient to be sustainable. Let's go step by step. The webinar is still 4:30, so I think by 4:15 I should be done. So 1, glycemic management. Choose approaches that provide efficacy to achieve goals. So use metformin or agents that have combination therapy, whether it is metformin and a DPP4 or metformin and a sulfonylurea, but you want to achieve your target of HbA1c of 7%, give or take, depending on how low you want this HbA1c. But always remember you're trying to avoid hypoglycemia. So do not overtreat the sugars to the point where you're getting hypos, especially in high-risk patients. When it comes to weight management, set targets for weight management reduction. Make sure you give them smart targets, achievable, smart, similar as you. So you set those targets and you can start with lifestyle advice, but then if it does not work, consider metabolic surgery, especially if they can afford it. Do not be shy of sending them to a surgeon for gastric bypass or for balloon therapy. These are things that are now available. Then use an evidence-based structured weight management program if possible. Then consider medication that can help with weight loss, like GLP agonists, like SGLT2 inhibitors. Avoid medications that make them gain weight. By the way, sulfonylureas cause weight gain. So every time you give this person glibenclamide 10 BD and you're wondering why their weight is not coming down, it's because of your drugs. So change them from that to something else. Use a DPP4 or use an SGLT2 inhibitor, or even, so use drugs that are not going to make them gain weight. Now, the third part is cardiovascular risk management. Look for them. Do not wait for someone to come with a heart attack or kidney failure. Keep on looking for these risk factors. Screen and surveil. Lower the BP, target 130/80. Lower the LDL, especially cholesterol, target less than 1.9. So keep them on statins. Any person with diabetes should be on a statin. Antithrombotic agents for those who need them. It's not everyone who needs aspirin or clopidogrel. Again, that's a topic for another day, but those who need them should be on them. And stop smoking. Those are very important risk factors to look at. Then now look at the other comorbidities. If they need their kidneys and their heart protected, make sure they have an SGLT2 inhibitor. I will not talk about GLP-1 receptor agonists because they're very expensive, but SGLT2 inhibitors right now, they can cost you even 1,000 bob a month. That is something, that is one dress. So me, whenever I see someone with the new shoes coming to my clinic and then they start complaining about drugs, I'm like, maybe next month, don't buy a shoe and take care of your heart and your kidney. So at the end of the day, you have a patient who is well taken care of. All the components of care are sugar control, that's glycemic management, weight management, cardiovascular risk factor management, and cardiorenal protection. All of them have been taken into consideration. So every time you see someone with diabetes, ask yourself, have I looked at the 4 pillars? Have I looked at the 4 pillars? Just remember that. If there's nothing else that you remember, just remember, it's not just about the sugar, it's about sugar, weight, cardiovascular risk, and cardiorenal protection. All those 4 in one. And then looking at the glucose lowering medications that are available. You remember we talked about healthy lifestyle coming first. And then we said after that, you look at the patient. If they have high cardiovascular risk or they have heart failure or CKD, give SGLT2. But if their issue is weight, then go for something that is going to help with their weight control. So that is most likely SGLT2 inhibitors or GLP-1 receptor agonists and metformin, okay? And then here, and then if you want to bring down their sugar very quickly, then remember the things that will help to bring down their sugar quickly are metformin, SGLT2, sulfonylurea, and thiazolidinedione, okay? If the issue is weight loss, then use drugs that are going to help them with weight loss, like SGLT2 inhibitors or GLP-1 agonists. The ones which are neutral are metformin and DPP-4s. Those ones don't really cause any weight loss, but it's also good because they don't cause weight gain. But at the same time, if you do not feel like your sugars are well controlled, always remember to identify barriers in their treatment. Consider DSMEs. Again, always ensure they have education and make sure you find out if the issue is that they just don't understand or they have not understood certain concepts. Consider technology that can help and identify and address any other factors that could be there, the social determinants of health that impact achievement of goals, especially money. So what is the importance of integrated care as we finish? One is that you acknowledge the lifelong and evolving nature of type 2 diabetes. Identify and coordinate with the team. Diabetes is not a one-man show. It is me with the nutritionist, with the medical officer, with the psychologist, with the counselor. You know, there are so many people. It is not just a one-person team. There's also the surgeon if you need to take care of the wound. You need an ophthalmologist to take care of the eyes, the kidney specialist. There are so many people who come together to form that integrated care. And then know the resources that you have available. Again, I will say this again. We have a partnership with Novo Nordisk that helps us to actually improve education to the patient. They give glucometers to the patients. They give them strips for a few days, and they even call them from home to ensure that they are doing okay if they have hypoglycemia. It's like a call center, and this is being given for free. So you see, these are the resources we are talking about. So right now, if you know of any patient who has been struggling with insulin or has been struggling with monitoring their sugar, refer them, let them get these resources that are available. And then language matters, ensuring that we talk well to our patients. Individualization of care. Consider each patient or each person who's living with diabetes as an individual. In their own context, they have their own risks and preferences. So it's not a one glove fits all. Then the healthcare system should address and monitor inequity in the delivery of interventions and address and assess social determinants of health and look for them in each person who is living with diabetes, especially ththose ones whose HbA1cs are not good. Find out why is it? And then incorporate comorbidities, ensuring you remember the kidney, remember the heart, remember the liver, remember the brain. So making sure we have all those comorbidities into perspective. And then diabetes self-management, education, and support, DSMEs. Embrace these as being important as medication. If you do not educate your patient, even when you give them the medication, there's nothing much you're doing. Identify and know how to access your local DSMEs, the resources around you. If you don't know what they are, you can even call me and ask me, Doc, please hook me up. I will hook you up. Impress upon the person and the healthcare team the importance of DSMEs in the ongoing holistic approach in the management of type 2 diabetes. Remember, it's not just the team, it's the person as well. They have to be at the center of everything. Initiate and refer at diagnosis annually and with any change. The husband has died. Let them go for another education. Are they having transition of care? Do they have cancer now? Let them go for another education. Have they now become bedridden? Let them go. Like, move with the patient in every stage of their life. Don't just assume that education they got day one, huyu amekuwa na diabetes 20 years, anajua hii maneno. They don't know these manenos, by the way. They have to get continuous education and support. Then facilitating healthy behavior and weight management, ensuring that they reach their targets and that they reach goals that have been agreed upon by the team and that there's shared decision making. Emphasize self-monitoring behavior. Review the data that's collected. Let them give you their sugar from home. Don't accept these sugars for clinics only, by the way. Next time, tell them come with a karatasi, written 10 sugars. Do you only 50 bob per sugar. Of course, I know there are some people who can't afford, and that's why we said social determinants of health. But majority of people can afford to do some few sugars at home and bring them for review. Track their weight, bring it for review. They can improve their physical activity, and it doesn't have to be the gym. It includes even just running around the neighborhood. Then anyone who's taking insulin or an sulfonylurea has to be educated about hypoglycemia, especially when they're undertaking physical activity or changing their diet. Then DSMEs and nutrition therapy can help the patient living with diabetes address any barriers and implement healthier lifestyles. Then the choice of medication, providers, ourselves, we need to keep on continually updating our knowledge. If you feel like you don't have enough knowledge, please, there are so many online courses you can do on diabetes. Please let us not be those glibenclamide and metformin people. I'm trying to encourage us to start thinking and not just writing things that our grandmothers can write. Me right now, see, I can just tell my grandmother to sit in the office and write glibenclamide and metformin for anyone. But now, if you have that additional education, then now you put it into perspective and see this patient, what can I give them? What can I change? Which medication should I change? Should I start insulin? You know, think. Then if you do not know that, if you do not have that knowledge, go back to school and read. We are always in a state of improving our knowledge. Then identify relevant comorbidities. Make sure you always have looked for them. Assess the profile of the person and determine how you'll treat them. Consider risk factors for medication-associated adverse events, and prioritize the use of organ protective medications. Again, SGLT2s. And then another one is thiazolidinedione for those who have steatohepatitis. People with fatty liver disease respond very well to pioglitazone. So always remember. So again, add to your list of drugs, and it's not expensive. Pioglitazone is a cheap drug, and it can be used very well for people with alcoholic liver disease, not alcoholic, sorry, fatty liver disease. Then the place of insulin. So GLP-1 receptor agonists are there, and it's in the guidelines, but it's quite expensive. So we tutaruka hiyo part. But the next part is when initiating insulin, start with a basal insulin and intensify the dose and titrate it to achieve a good fasting blood sugar. Then continue insulin and other organ protective medications and metformin. So basically what we are saying is do insulin, do SGLT2, and do metformin. Don't just go to insulin and you're like, sasa tuko kwa insulin. No, continue metformin, continue SGLT2 inhibitor. Then refer for education when you're initiating insulin or advancing from once a day to 3 times or 2 times a day or 4 times a day. Make sure a patient is still being continually, actively being taught. The place of insulin should always be remembered. If you have someone with severe hyperglycemia, an acute glycemic dysregulation like an infection, surgery, etc., or anyone who you think has type 1 diabetes, initiate insulin. And always remember, we start with a basal insulin at 10 units or 0.1 to 0.2 units per day, titrating to fasting blood glucose. But at the same time, if the sugars are not well controlled, because we do not have GLP-1 receptor agonists, we usually go to multiple injections, either pre-mixed like Mixtard, Novomix, Humamix, etc., or we go to basal bolus or basal plus, which means you have a basal insulin, and then you have random insulin as well. Then you keep on intensifying along the way and maintaining healthy behavior, nutritional counseling, and education, making sure they are injecting themselves well, they're avoiding hypoglycemia and avoiding weight gain. So those are some of the things you always have to remember. And we always have to work within the system. By the way, we all wish we were in Canada or the US, but Kenya ndio iko. The system does not work. It is what it is. We have to work within it. So we need to always ask ourselves, okay, fine. We know we live in a broken system, but what is my role in this broken system? How can I make things better? I know things are not perfect, but at least I can do something. So what we can do on our part, even though our system is not the best, sometimes we can also work on ourselves. Improve your education. Make sure that you identify each part of the the members of the team that manages people with type 2 diabetes, get them together to work together. So let's not work in silos. We can work together, and we do team-based care, so that yes, our system is broke. We are not saying we are perfect, but we can try our best to create a team-based care, including all these specialties together. And that is why it was very important for us to have that medical camp as an integrated medical camp 2 days ago. We included ophthalmology, ENT, dental, NIN, because all those people work together to make sure that the type 2 diabetes patient is well. And it is continuous quality improvement interventions tailored to the local setting. So whatever we have is what we're going to work with, and we are going to make the best of whatever situation we have. We are not going to be in heaven, but we'll make our little heaven in our little local setting wherever we are. And then how to really make it work is to arrange, make sure that we know who is delivering care, coordinating care of our patients, managing the care processes, making sure we have ICT involved in the treatment. We make sure that we have our policy and governance as well, which includes training and certification. And that's why I keep on saying we go back to school. There are many courses for nurses, there are many courses for clinicians. Make sure you get some training and certification and improve our quality of practice. And then at the end of the day, we implement through the health system, the healthcare setting, and healthcare workers. And at the end of the day, remembering that our patient is not just sugar, it's not just diabetes, it is kidney, it is heart, it is endothelium, atherosclerosis, MI, stroke. All these things are what we are trying to avoid for our patient, so that we can have a healthy patient who does not die early. And as I close, I just want to remind us that these are photos from our camp. This is the lady from Novo Nordisk who came with this kit called the NovoStart. And they gave this, as they were giving this structured education to many people living with diabetes that day. They gave this kit, which included glucose strips, glucometer, all for free. Glucometer, glucose strips, they taught them how to use it. And she actually is being called by the patients whenever they have challenges. She calls them, and I would encourage us to ensure that we work together with them and to work together with the team at hand. This is our own nutritionist. We have diabetes educators like Edna around, and we can work together to create our own team in our hospital. And wherever you are, if you have your nutritionist, if you have a nurse who is good with diabetes education, use them. Create your small little team that can help to manage the patients that you have. And a reminder that we are always working to educate to protect tomorrow. So our main thing is we want to try and reduce our complications. And like I told you that there's a place where you can go to access free diabetes education that you don't have to pay for. It is this one, just screenshot, and then you can go there and just do the course and understand diabetes education. But there's also another place, there's another site called Diab Africa, DIAB Africa, which actually also is a free treatment, free education site for healthcare professionals for diabetes. So you can still go back to school, online, learn, study, and even have certification on diabetes and improve your care to the patients. So thank you very much. I'll now take it back to Golobe. Thank you, Daktari.
Thank you very much, Dr. Hilda. That was very good. I have seen quite a bit of comments that are expressing their gratitude at this particular webinar. And a good number of them are also asking for these slides. So I think we'll leave that with the KNH team to avail the slides to people. So I think what I've gotten from this particular webinar is that, one, diabetes management requires a concerted effort by many teams. Second, we should try and educate our patients every contact we get. We should give them education on how to manage, on how to prevent complications, and on medication use and follow-up. Now, I have quite a number of questions here. So I'll see if we can tackle a good number of them. I don't know that we'll be able to finish all of them at once. So let me start with Rose has asked, can we make diagnosis of diabetes from doing HbA1c only, or is it a must to do an OGTT?
Yes, so Rose, yes, you can make a diagnosis of pre-diabetes and diabetes with HbA1c only. You do not need an OGTT. Pre-diabetes is between 5.7 to 6.4%. Anyone who has that has pre-diabetes. Then anyone with 6.5% and above has diabetes. But a small disclaimer is that HbA1cs are supposed to be done in a standardized fashion. Very few labs in Kenya actually do the legitimate standardized HbA1c. So sometimes you'll get people who have a bit of discrepancy, but yes, the targets, the set numbers are that 6.5% and above diabetes, 5.7 to 6.4 pre-diabetes.
I think we lost you there a bit, Dr. Hilda.
Oh, sorry, 5.7 to 6.4% is pre-diabetes.
Okay.
Yeah.
All right.
Mm.
Thank you. The next question is from Anonymous, I guess. So, hi, doctor. I have a client who was diagnosed with gestational diabetes 2 years ago during her first pregnancy. She's been on treatment, but it has not resolved to now. She wants to get another baby. How can she be assisted? So I think the question generally is a patient who had gestational diabetes and then got type 2 diabetes and wants to get another pregnancy.
So that's a very important and good question. Remember, anyone who has diabetes and is planning to get pregnant needs to get a planned pregnancy to avoid risks to the baby and to the mother. There's higher mortality and higher miscarriages for people who get unplanned pregnancies in diabetes. So this patient should first be well controlled before they get a baby, but they can get a baby. So first of all, the best thing is to ensure that they are well controlled, ensure that they are on medication that is bringing down their HbA1c to 6.5 to 7%. And their fasting blood sugar and postprandial sugar is within target of 4 to 7 and 5 to 10, respectively. And now once that is achieved, then they can now start for trying for a baby. And during pregnancy, it's important to note that because of the placenta, there can be a lot of insulin resistance. The sugars can go higher. So they need to follow up very routinely and be in a high-risk ANC clinic so that even if their sugars are high, they can be started on medication that can help. Also to remind people that the only safe medicines in pregnancy are insulin and glibenclamide and metformin. So if they're on other medications like DPP-4s and any other medication, they have to be stopped and they need to be titrated onto the medications that are safe in pregnancy. So that is why it has to be a planned pregnancy. But the answer is yes, as long as the sugars are well controlled and they get followed up in a high-risk clinic setup where they are being really monitored very closely, yes, they can get pregnant.
I think I'll add a bit to that as well. Gestational diabetes also increases your risk of progressing to type 2 diabetes. So in these patients, please remember, if you come across them, to encourage regular monitoring of their sugars. So up to 3 months post-delivery, they should always be followed up. And even after that, even if their sugars seem to have returned back to normal, encourage them every year to check on their sugars so that we can catch any type 2 diabetes that starts earlier rather than later. Yes. So, all right. Next is another anonymous attendee. So the question here is a 40-year-old female with a fasting above 7 on 2 occasions and a HbA1c of 8.9. Also has a positive family history of diabetes, however, is not overweight. She's been counseled on and discussed about diabetes, but she requests to start with lifestyle modification before you initiate treatment and has completely declined any medication. So Dr. Hilda, the question to you, how should you proceed with this particular patient? And I would like to say this is actually a very common occurrence in most patients who check in with type 2 diabetes.
Yeah, that is very true. So this person definitely has type 2 diabetes, and that's a good point you've brought up, that they are not obese, because it doesn't mean that everyone with type 2 diabetes is obese. Some have normal BMI and they have diabetes. So sometimes it's genetics, sometimes there's other factors involved. So this person is definitely living with diabetes. But if it has been quite some time, and they're trying lifestyle modification and the sugars are not coming down, then it's time to have another discussion with them. Let them understand the importance of bringing down the sugar, that it's not about the figure, it's about the avoidance of complications. Sometimes the education that they have, they don't really know that high sugar ties in to kidney disease, to eye disease. They're not very clear about that. So it has to be very clear to them that they're increasing their risk and chances of complications every time they postpone getting medication. And by the way, there are some studies that have been done that show that the faster you start combination therapy in patients who have elevated HbA1cs like this one, the better it is in terms of outcome of avoiding insulin in the long term. Because, you know, type 2 diabetes, initially you will start maybe with only orals, but many times the pancreas keeps on getting weaker and weaker. And then after a couple of years, maybe 10, 20 years, the patient is no longer able to secrete insulin and turns into getting insulin. So it almost becomes like a type 1 diabetes. So earlier intensification of therapy helps to reduce the progression of disease so that they don't need insulin as soon as they would have. So this is a patient who needs to be educated. What I would do is to actually do a counseling session with them, find out what is the main barrier, what are they scared of, what are their fears that they have with initiating medication, and then also at the same time try to explain to them the importance of starting, the importance to reduce complications and avoid complications. But at the end of the day, remember we said it's patient-centered. If they still do not want treatment, by the way, they will not take it, even if you give it to them. So you have to slowly get the patient to your side by intensifying education, intensifying psychological counseling to identify any barriers, which could also be psychological, which could also be depression. So you need to identify other associated factors that could be causing this patient to not want to start medication before you give up on them. So do not give up on them. This is very common, but many times I've found out that there's a barrier. There's either they have not understood certain concepts, or they have other psychological issues that they need to deal with that are making them refrain from starting medication. So do not give up on the patient. This is where your structured medical education is really required. So make sure that you give it to them.
Okay, thank you for that. And I think I'd like to stress a lot that in diabetic patients, patient education in the earlier contacts, when they get diagnosed and the following month, is very important in trying to explain to them why they need the treatment. And the fact what Dr. Hilda has mentioned as well, that what you're trying to prevent is future complications. I think once patients understand the gravity of that long-term uncontrolled diabetes leads to other bigger problems, leads to heart disease, leads to atherosclerotic disease, leads to loss of limbs, dialysis. Once they understand that, they might be in a better space to agree with treatment and actually start and initiate and continue with it. All right. Hi, Isaac G here says, there's an increased tendency of our diabetic patients to miss clinics and opt for Chinese remedies or alternative medicine. So how safe are the Chinese products? And is it worrying that even I am assuming this is community health volunteers, are being used to identify diabetic clients for enrollment into these alternative medications?
That's very interesting and very important. One of the things that I've realized about us is that we are not good salespeople. Just generally, we are very poor at sales. When you compare us and someone selling a Tianchi product, they do way better than us, by the way. Me selling metformin and them selling Tianchi wins, because we don't know how to package. We don't know how to frame these things. We don't know how to communicate to the patient, and we do not know how to involve the patient in our decision making so that it's a decision cycle. The Tianchi guy will already show this patient or this person how they are going to benefit through network marketing. They will tell them how, it's not even just you. Once you start and then you sell to 10 of your friends, you're going to gain blah, 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 So we need to learn how to sell these medications and the idea of these medications to the patients. And one of these ways is by involving them in the decision-making cycle. That's why we went through this decision-making cycle, because once you and the patient look like you're in a team working together, and it's not just me telling you what to do, then it's much easier for the patient or the person living with diabetes to say, you know what, yeah, this is teamwork. Let's do this. Let's try this and see. It's very important to note that majority of these drugs don't really have any scientific evidence. And I'm not saying that there's a problem with herbal medications, by the way, because there are some herbal medications that, for example, malaria medications are literally all herbal medications. Most of the cancer medications are herbal medications. So it's just that they extracted the particular compound that treats the cancer. They extracted something that treats malaria. So that is why it's very difficult to tell them not to use certain drugs, because they see it can work. Sometimes their sugars even go low because of these things that they're using. But it's just that you don't know what else is in this compound. Studies have not been done to show its efficacy, to show its side effects. So they are taking something that they are not very clear on what the actual benefit is. And sometimes I actually tell them, chukua hiyo dawa, then ufanye sugar before and after eating, alafu uchukue hii dawa yenye mimi nimekupea na ufanye sugar before and after eating. And by the way, they will realize that the drug you are giving them is working better than the other one, and they will stop. So don't just vilify them. Don't be like, no, don't take. You can say, oh, you're taking it. Ah, sawa. Why don't you check its efficacy? Why don't you see how well it's working and compare with the other one and see? So try to get language that is not judgmental on them, and at the same time look like you're actually interested and you are actually because at the end of the day, the patient is your main responsibility. Have that engagement with them on a one-on-one basis, but don't throw them away. Just let them see for themselves the difference between the efficacy of the two. Because the good thing is that we have science on our side. So because of that, we know, like I know that insulin will make the sugar go down. The Tianchi probably will not. But let them be the one to discover it, and then look like you have supported them through the process. Don't chase them away. And then the other thing that I wanted to add is the value of support groups. Actually, even for that person who had a HbA1c of 8.9 who has refused to start any medication, link them up to a support group. There are some support groups which are very strong. I remember the time I used to work in Chogoria Hospital. We used to use the support group for some of these patients, because these are people who now have diabetes and are living with it, and they have seen the benefits of being on medication, and they come and talk to this person. And some of them used to be in denial like this person, and they come and give them their own experience and tell them, you know, I was just like you. It was very difficult for me to accept the diagnosis, but when I did, life has changed. I feel so much better. So when they see that someone else has gone through what they've gone through and they're successful, then it's much easier for them to even change their mind. And the same goes for these Chinese things, because all these people in support groups, majority of them have tried these things one way or another. They have gone to Tianchi, they have gone to these other Chinese stuff, and probably didn't work for them. But now when they give this experience now directly to others and they share amongst themselves, it's much easier for a new person to feel at home and feel like, you know, this is a team of people who actually understand what I'm going through. So support groups among the patients themselves are very important. And I would encourage each of us to see how we can build a support group for people living with diabetes wherever we work.
Thank you for that. And I'd also add about this supplements, so to speak. I think patients have a problem differentiating between helps in controlling sugar and cures diabetes. So if you explain to your patients that some of these things, the question down below about chromium in the management of diabetes, some of these supplements help in controlling the sugars, but you cannot say that they lead to a cure of the disease. So try and explain to your patients as well the difference between control and cure of diabetes.
And actually, at the same time, also making them understand why the diabetes came in the first place. There are many people who have come to me telling me about these drugs, which are mostly very expensive. And I tell them, you know, you don't need this. If you just lose 10 kilos, all these things you will not need. Focus on your weight loss journey. when you redirect them and show them where they need to put their energy, many times it really helps them to gain clarity. But that again goes back to education, educating your patient for them to understand why the diabetes came, how it can be reversed if it can, and how it can be controlled, especially those who are obese. Weight loss is far superior to any chromium, any diabetes, I don't know what they're called, but those things are actually very expensive. And when you compare with what they would get from weight loss, it's a no-brainer. Weight loss will always be superior.
Okay, thank you. Ongeri is asking, why is it that when one is hypertensive, eventually he or she becomes diabetic also? And does HCTZ predispose one to becoming diabetic?
So that's a good question. It's very true that the two are often interrelated, hypertension and diabetes, but most of the time it's just because both of them are lifestyle diseases of our lifestyle. Sedentary lifestyles, weight gain, both of them are directly linked to that as much rather than it being that the hypertension is the one which brought the diabetes. It is just that the risk factors for both of them are usually the same. But that said, the proportion of people living with hypertension is much higher than those living with diabetes, by the way. It's just that majority of the people with diabetes have hypertension. I hope you get the difference. So the prevalence of diabetes is 3.3%, as Dr. Ngolobe had said. The prevalence of hypertension, on the other hand, is around 25 to 33% of the population. So you'll find that many of the people with diabetes have hypertension, but many of the people with hypertension do not have diabetes. So there is no direct link really that HCTZ is the one which brought the diabetes. No, it's just that the risk factors for both are usually mixed. It really involves the whole sedentary lifestyle change that we see. But hypertension also has a very huge component of it being genetic. So people who get essential hypertension, they're very slim, they're very but they have a very strong history of hypertension in the family, then they end up having hypertension themselves. But at the end of the day, there is a link between diabetes and hypertension. Why? When people get diabetes, there's a lot of changes that happen in the reticular, I'm about to say reticular endothelial, in the RAS system, the renin-aldosterone system. And because of that, they have increased intraglomerular pressure, and that directly leads to sodium retention and actually predisposes directly to hypertension. So it's actually a lot of people with diabetes get hypertension because of those factors. The RAS system has been overactivated and it actually leads to hypertension directly. Yeah. So hypertension sometimes can directly lead to diabetes, but mostly it is just through insulin resistance and through weight gain.
Mm-hmm. Okay. So Rose has a question that I think borders on systemic issues in the facilities. So the challenge we experience managing these patients is that they complain that every time they come for a visit, they find a different doctor who, depending on their current complaints, changes their treatment. Sometimes treatment ends up not being consistent. Her question is, what can we do as we implement the revised regime? And she also notes that mental health should also be a mandatory requirement in their management. So I think the question is what to do when you have patients who come mostly in public facilities, because then you find the doctor on call or the doctor around on that day is the one going to manage.
Yeah. What do you think, Doc? You've been in
there's little you can do to change the public system in terms of which doctor sees you. You are not in control of that. But I do believe in diabetes, we already have guidelines that almost every other country uses to manage these things. So as long as these guidelines are delivered to the primary care doctors, their changes would most likely be within those guidelines. So the treatment cannot be so far off that you will impact this patient adversely. Maybe just a change in what drug and the drug doses, depending on the sugar control they have. That is one. Second, like Dr. Hilda said, always insist on getting the patient's glycemic control at home. The patient might come that day and they didn't eat breakfast, and they came and they ate a cupcake and soda while they were waiting for the clinic to start. So they'll come check in with a sugar of 16. You cannot now assume that all their previous sugars have been that high. So when you act on one sugar only, it might cause a bit of an issue. It is easier if you ask them for self-monitoring of blood glucose from home. Then you can see the trend. Then you can explain one deviation, which might actually help in management in the long term. So that would be my view on that.
Yes, I agree with you, Doc. I mean, it's quite a very difficult issue to tackle, because it also goes to how many, do we have enough doctors? Do we even have enough healthcare providers to start with? So there's a lot that goes into it. But I think at the end of the day, when the patient realizes that they are the ones at the center of their own management, and when they are educated and empowered enough to take up that mantle, then it's also easier for them to deal with any doctor who comes their way. But that's why it's also important for us to talk with the same narrative and have education that gives us the confidence to say the same, to have the same guidelines of treatment for all our patients, so that it's not that when they see Dr. Ngolobe tells them one story, then Hilda comes, tells them another story. So having a structured way in which we give the same message to our patients will make them then see us as all healthcare providers, not, I want Hilda because she told me this. I want Ngolobe because she told me this. It will be easier for them to actually accept any person, because they know it's the same message being spread by the team. And that's why it's important to work as a team, not as me. It's not a one-man show, and it's not about Hilda being the savior. No, it is all of us working together to ensure that our patients get better.
Definitely. The next question is basically around treatment. So what is your advice on stepping down treatment on patients who have well-controlled sugars? So they gave a clinical scenario of a patient who came in with high sugars, was on metformin 850 BD, glibenclamide 10 morning, 5 nocte, or no, 10 nocte, 5 morning, and then their sugars stabilized. So can they step down the treatment to metformin 500 BD and glibenclamide 5 BD?
Okay, that's a very good question. Remember, we said there are various things that we are looking at for different patients. So for this patient, maybe our issue was glycemic management, and now you have reached your glycemic management. But always look, do you have any other issue? Are your kidneys okay? Is your cardiovascular risk okay? If it's not okay, then perhaps you might want to change from sulfonylurea and shift to SGLT2 inhibitors or a DPP4 inhibitor. Maybe the issue was weight loss. Maybe now they've lost 10 kilos, for example, and that is part of the treatment strategy. So always ask yourself, okay, fine, now we have lost 10 kilos. What can we do differently in our management? So I agree, stepping down treatment is very important, because it also gives the patient motivation that, hey, I've been working so hard, I've lost 10 kilos, and now I have been able to come down, step down on my medication. I remember just 2 weeks ago, there's a patient who is now on only one pill. And initially we started on insulin, then went on orals, like 3 orals, then 2, then 1. So yes, stepping down is important, but only do it when you're sure that you're also looking at various factors in the patient's journey. Make sure that you've addressed the pillars of treatment. Make sure that if they have an issue with weight, they're working on it and they're continuously working on it. Make sure if they have cardiovascular risk that's high, or CKD or heart failure, that they still remain on an SGLT2 for cardiac and renal protection. Don't just stop everything. And then for this particular case, as long as the sugar is well controlled and they're not they're not getting hypoglycemias or hyperglycemias, you can continue going down on the doses. So that's a very important thing, but always individualize. It's not just a step down for everyone. You always look, what patient do I have in front of me? What are our treatment goals? And what is it that we are trying to achieve? So once you look at that, then you decide how you can step down on the medication.
Okay, I agree with that. There's a very important question here, or comment rather. This person is called Magda or Guido. Is asking you to comment on vaccinations by people living with diabetes. The example he gave is COVID vaccine, hepatitis B vaccine, and Vaxigrid. I think it's very important in terms of vaccination and diabetes, considering diabetes is an immune suppressed state.
Yes.
So in my opinion, I think advise your diabetic patients, especially those with poor control, but just all of them in general, to get the general vaccines, pneumococcal vaccine, influenza vaccine, meningococcal vaccine, COVID vaccine, definitely. So let them get vaccinated to reduce the risk of catching infections that in the background of diabetes tend to present worse than a non-diabetic person. Anything to add there, Dr. Hilda?
No, I think that's actually really, you're really right. So they need to always ensure that the flu vaccine is a COVID vaccine, and hepatitis B as well. And yeah, so let's just ensure that our patients are well taken care of, for sure.
Mm-hmm. Genevieve Wanjala is saying, if one occasionally gets a BP reading of 145/77 and 140/76, is this unhealthy? Well, Genevieve, it depends on your version of occasionally, but technically systolic pressures above 140 are not normal pressures. So those ones need to be looked into for sure. It is better if you are getting such pressures to take a record of your BPs, as opposed to just present with two random values. We prefer records so that we can see the trend. But 145 and 140 systolic, those are not healthy BPs. Okay, Patrick Jenga, greetings, and thank you so much for the insightful and timely presentation. The question here is, can you start finerenone in a type 2 diabetic who has no features of nephropathy, and can it be used together with an SGLT2 inhibitor?
Finerenone.
Yes.
Yes, it can. Actually, it's the new kid on the block for diabetic nephropathy. Very good to reduce the intraglomerular pressures. And you remember we talked about hypertension coming in diabetes, usually because of intraglomerular issues. So finerenone has been shown to really, really help. It is a non-steroidal mineralocorticoid antagonist, much like spironolactone and eplerenone, but it works differently. So it actually really helps to reduce the pressures in the kidney, and it helps to improve diuresis. And it's been shown to have improved outcomes for diabetic nephropathy. Yes, it can be used together with the SGLT2s.
Mm. All right. So there are two people here who would like to get advice on how they can improve, what is this? Their knowledge on diabetes. One is a nurse looking for a specialization course. Another one is an MO. So do you have a place you can forward them to?
Yes.
They should get in contact with you.
Yeah,
get in contact with Dr.
Or even with Kennedy.
Or KDSG.
Yes, or KDSG or Kennedy. Then I'll tell Kennedy which site. Yes.
So Dr. Okok Carol is complimenting you on your presentation, great presentation. And she's asking if you could have a later webinar that touches on choice of meals and the blood sugar control for inpatients. So she works in a public facility and has noted the discrepancy between meal times and the times they give medication and the glycemic control. So what considerations should be made to manage this effectively? I agree with that, definitely. In public facilities especially, it's difficult to get control when your meals are very erratic and your medications are on schedule, especially insulin. I do believe that does require another webinar by itself, and that one also might require us to involve other practitioners like nutritionists to give us better advice on that, or to help in changing the system with regards to that.
But I think if you fight hard enough, you can change these systems. Things can get better. So yes, that's a good fight to have, because it's ultimately it's even cheaper for the hospital to reduce the carb content.
There's a question here. I don't think I understand it very well, but it's Paul Omondi asking, how can you help a patient with diabetes who has worrying weight reduction? So I'm assuming they're worrying about their weight reduction. in a diabetic patient.
So how will you help? Sorry, that part. How will you help?
How can you help a patient with diabetes who has worrying weight reduction? So Paul, I don't know if the weight reduction is the problem, they're reducing weight unintentionally, or that they're not reducing weight is the problem.
And actually, when you have someone losing weight in diabetes, you have to be very careful of two things. Either one, they're becoming insulin deficient. Remember, insulin is an anabolic hormone. So when you don't have enough of it, then you end up losing weight. And it's actually one of the signs that someone with type 2 diabetes needs insulin replacement. But also another thing is malignancy. You have to look for malignancy. Remember, diabetes is also a risk factor for GI malignancies, for example. So this is a patient who you really also need to screen for malignancy, but also check for their control, and they may need insulin. So I think if the issue is that they're losing weight, that is.
Okay. Dr. Rabiswa, what is your perspective on a zero carbohydrate diet in management of DM? That is an anonymous attendee asking.
Okay, that's
So
otherwise
I'm assuming that's a keto diet.
ketogenic. Yes. So keto diet, if it is well structured and if you are under the watchful eye of a nutritionist and a diabetologist, and if the person with diabetes has a glucometer that not only checks for sugars but also checks for ketones, and therefore it's easy for them to monitor and check whether they're becoming ketogenic and getting ketoacidosis, then it can be done under supervision. I will say that I do believe in a balanced diet. I believe in something sustainable. I believe in you doing a diet that even 10 years, 20 years down the line, you're still able to maintain the same diet. And it's very difficult to say that over ketogenic diet. So that's why I generally prefer that my patients have a diet that is sustainable and that is something that is just healthy and balanced. Carbohydrates are not bad for the body. It's just that too excess carbohydrates will lead to weight gain. But generally, carbohydrates are a very good source for energy. So it's still important for someone to have a small amount of carbohydrate in their diet. So what I prefer telling my patients is to go on a low carb diet rather than a ketogenic diet. However, if they do want to go on a keto diet, then it's fine. First of all, I have to approve, looking at the kind of profile they are. I do not approve it for people who are insulinopenic, people whose insulin levels are very low, because these are people who can easily get into ketosis and get diabetic ketoacidosis. So people with type 1 diabetes or people who are insulinopenic, which means that they're producing very little insulin now, they're probably on very high doses of medications, then I generally do not prefer that kind of a diet. But the ones who do it, I still do it under close supervision. I don't just let them go. Keto diet for any other person who's not diabetic is fine. It's a great way of losing weight quickly, but it's also not very sustainable. But for someone with diabetes, they have to really, really keep an eye, because you do not want to have ketoacidosis.
Thank you for that.
Okay.
We're
Dr.
being
Amanda?
chased away by KNH.
Yes. We are getting
Kennedy, I have 31 more questions to go through.
Yeah, those are too many.
I'm thinking we might be forced to redo this presentation, Doc. Usually what we do is compile all the questions again together, then we find a favorable day. We can also host another webinar to be able just to have a Q&A session for pertaining to this topic. Because I've seen questions are so many. You see, we still have like 30-something to go. It's a topic.
We can't deal with them.
Yes.
All
So
right.
maybe your parting shot as we mark this day, and also maybe Dr. Ngolobe, parting shot. Yes.
Sorry, before I give a parting shot, Kennedy, please let me just address one more question. I've seen two of them on the same topic.
Okay.
And this is on insulin and sulfonylureas.
Yes.
So there's a person here asking about giving insulin plus sulfonylurea for a patient who has poor control of diabetes. I've lost that question, but that generally is the shift of it. So I insulin and sulfonylureas is not a very good combination to give because of the risk of hypoglycemia. You can combine insulin with other oral hypoglycemic agents, insulin metformin, insulin SGLT2s, insulin BP4s, but insulin and sulfonylureas, try and avoid it because of hypoglycemia risk in your patients. If there's anything you can add, Dr. Hilda, on that quickly before we start giving our parting shots.
Yeah, no, I totally agree with you. However, sometimes when you start a basal insulin, you can keep on the SU but reduce the dose. But I would encourage that generally, just to make things easier, just when you start an insulin, stop an SU, unless you're very keen and you have very tight watch over the person to ensure that they don't have hypoglycemia. Just stop SUs when you start insulin. It's much safer that way. Remember, we still want to be safe doctors. So safety is number one.
All right, now that we've been booted from this webinar, Dr.
So my parting shots. First of all, I would like to say that I am so impressed by the overwhelming attendees, the number of questions. It means that there's a lot of the people out there are hungry for knowledge, and I'm happy about that. My parting shot is, let us educate ourselves so that we can have the same narrative being spoken to our patients, so that whenever they know that even if they go to a health center or they go to Kenyatta or they go to Aga Khan, they will get the same quality, concise, and well thought out decision plans, no matter where they are from. It's not about how much money the patients have, what they can afford, but it's about what quality education we can give them, because the minute we give them quality and proper education from the beginning, then we will change a lot of the narratives that we have. We will reduce the number of complications, we'll reduce the number of people in ICU and the people starting on dialysis that I have been seeing, because it's very worrying. So let us educate ourselves so that we can educate the patient and the people living with diabetes. Thank you very much.
I agree very much with that, Doc. Thank you for that. Thank you very much for giving us a wonderful presentation. I was hoping your camera would be on so that I can give credence to my young and beautiful introduction, but we've already confirmed that you are very intelligent. So thank you for that. I hope KNH will be able to disseminate the slides.
Yes,
probably, yes, a good amount of the questions we are getting here might be answered by people reading through the slides, and also requests for the pages where people, oh, there she is, you see?
I hope I'm beautiful enough for you.
All right. Ladies and gentlemen, there is the legendary Dr. Hilda Nabiso. Yes. So parting shot, please, as Dr. Nabiso has said, educate yourself so that you can educate your patient. The only other thing I will add to that is please proactively look for complications so that we can be able to manage them earlier and prevent worse outcomes in our patients. Thank you very much for your attendance. Thank you very much for your time. Thank you, KNH, for this platform. I will hand it back to Mr. Okinda.
Thank you very much, Doc. Thank you very much, Dr. Hilda. We've worked tirelessly this week. I don't know where you are, if you are having a rest. I think you really needed, if you had the capacity to allow you to rest by the beach, because you've really had a long week with 2 medical camps that you really hold, which was quite successful. So we thank you very much for your dedication and commitment. My parting shot to everyone, kindly educate yourself, just as Doc has said, so you can also educate others. And also, please refer your patients to Moi Kibaki Hospital. You can see the expertise that we have to attend to your patients. So you'll be rest assured that the patient you refer will get indeed the quality of service that they require. So from us and from the organizers of this webinar, I say thank you very much. For the CPD points, Nell will be able to share as a normal way that we used to do. All the best and good evening to everyone. Is exactly 4. I think we've done so well in terms of time management. Thank you very much. Bye.
Bye-bye.
Goodbye.